And at this point, I'd like to invite Senator McBride.
Thank you so much, Tim. My comments are going to be briefer than my introduction. It's so wonderful to be with you all, and can we give Tim and the Academy a round of applause for bringing us together? It's wonderful to be with you all at the Delaware State University, an incredible institution here in Delaware that is training the next generation of leaders, including in healthcare. And so it's a fitting place for us to come together for this conversation. I believe there are few issues more at the heart of the future success of Delaware than building our healthcare workforce as we face a growing and aging population and the pending retirement of a lot of your colleagues. This is a topic that needs to be at the top of the priority list for policymakers at the local, state, and federal level. And it has been an incredible privilege over the last 4 years. It continues to be a privilege to serve in the Delaware State Senate, and in that capacity to serve as the chair of the Senate Health and Social Services Committee. And as I stand here before you all looking out at this room, I see so many people who I have had the opportunity to collaborate with and to learn from over the last 4 years. One of the privileges of serving in public office is that you get to see the goodness that fills our state of neighbors. And as the baby of the Delaware State Senate, I get to quote Mr. Rogers. I'm allowed to as a young person. And one of my favorite Mr. Rogers quotes is a quote he used to say about how when he was younger and he would see something scary on the news, his mother would tell him to look for the helpers. And as an elected official, you get a front row seat to the helpers that fill our state. And there is no sector of our society where that love for our neighbors, that neighborly duty to care, where those helpers are on greater display than in healthcare, than in the folks who are in this room and those who are doing life-saving work around our state at this very moment. The other joy of serving in public office is you get to have really incredible conversations, sometimes where you agree and sometimes where you disagree. But the folks in this room, I think, have displayed in really profound ways the Delaware way at its best. A desire and a willingness to come together to find common ground, and when common ground might not be able to be found, to disagree agreeably. And the policy conversations that we have around our healthcare system, around our healthcare ecosystem, around workforce, they are complicated and sometimes very difficult conversations. And while there is a lot of common ground to be found, I'm sure there are some issues where even the people in this room don't always agree. But what I have always found is that every single person in this sector that I have had the opportunity to collaborate with comes with a willingness to listen, a willingness to extend grace, and a willingness to have those difficult conversations across disagreement. And because of that, we have made important progress over the last several years. As the chair of the Health and Social Services Committee, I've been proud to work with my colleague, Senator Townsend, and many of you to try to grapple with what too often feels like an intractable challenge with our primary care professionals. And I know that is an ongoing conversation that we need to continue to have. Working with many of you, we've reestablished and enhanced the state loan repayment program for many provider types here in Delaware. We've reformed some licensure policies that, as I think you have heard earlier, have helped to reopen previously closed clinics or clinics operating at reduced capacities at our federally qualified health centers around dental care. We have reformed our state's mandatory reporting rules to grapple with provider burnout, changing the rules that were particularly draconian for physicians, as well as updating policies for all healthcare professions to make sure that we are providing pathways toward the full range of healthcare that our caregivers need and they deserve, including mental health care. And working with many of you, including our state's hospitals, I was proud that just this past June, the General Assembly unanimously passed what we called the Protect Medicaid Act of 2024, which will, after a two-decade conversation here in Delaware, finally establish a hospital assessment to join the vast majority of states that use that critical funding stream to support, protect, and expand their state's Medicaid program. A new revenue stream that will bring in the largest ongoing investment into our state's Medicaid program since the Affordable Care Act was passed in 2010, hopefully allowing our state's Medicaid program to not only expand coverage, but to improve reimbursement rates across areas of care. So we've done quite a bit together, but we know we have so much more work left to do. There's so much more work that you've discussed here, and I know those conversations will continue with everyone in this room and beyond, with elected officials at every level of government around affordable housing and affordable childcare, around guaranteeing that we're building in-state the career pipeline for healthcare professionals. And I look forward, in whatever capacity I may have come January 2025, to continue to work collaboratively with you all to guarantee that we are adopting the policies and securing the funding to train the next generation of healthcare professionals, to support you all in this work, and to grapple with the shortages that we continue to face that undermine access to quality care and, frankly, only deepen the challenges that we're facing with workforce shortages in healthcare, because we know when there's not the staff present, not only does that impede access for patients, but it puts an unbearable strain on healthcare professionals that pushes more and more out of the workforce. And so these conversations will absolutely continue, including—
Left, right, left, right.
Well, that's an interesting, maybe that's part of the next presentation. And with that, we will have this conversation today continue with our final speaker, who I have the privilege and pleasure of introducing. Rachel Block is a program officer at the Milbank Memorial Fund, where she focuses on a variety of state health policy issues. She's previously served in a number of executive roles in the public and private sectors, including spearheading development of New York State's Health Information Technology Strategy as Deputy Commissioner for Health Information Technology Transformation in the New York State Department of Health, say that 5 times fast, and as the founding executive director of the New York eHealth Collaborative. Ms. Block has worked at the Centers for Medicare and Medicaid Services, where she's held several senior management positions directing policy development and operations for Medicaid, the State Children's Health Insurance Program, and federal survey and certification programs. She was the founding executive director for the Vermont Health Care Authority and had senior health policy staff roles in the New York State legislature. So with that, please join me in welcoming Rachel Block to the stage.
Okay, they put me in charge of some technology here, so, oh, blink screen, okay. Let's see if I can do this. All right, IT guys, I might need help. Oh, wait, oh, I got it. See, I use a Mac, and this is not a Mac. Here we go. Are we good to go? So in the meantime, thank you so much for having me. I do recognize I'm at the end of an incredibly rich discussion. I have been with you pretty much the whole day. And so I wanted to learn more about some of the specific things that you are working on, but also this is very much in my roots. I told Tim when he reached out to me about this meeting that actually when I worked in the New York State legislature, and I hate to say it was over 40 years ago, my initiation was professional licensing legislation. Imagine that as your first professional responsibility. It was quite a learning experience, but it certainly gave me a lot of the tools and skills that I have used subsequently. Just also would like to acknowledge Tim and the team that put this together, but also to note, as I'm sure every one of you knows, when Tim introduces himself, one of the second or third things he'll say is, you know, I'm a Quaker. And I have to believe that that is one of the main reasons that he's been successful in pulling together this coalition and gotten so much support and cooperation from so many diverse stakeholders. I'm going to leave you today, though, with a little bit more compelling reasons why you do need to keep this conversation going, not only within the context of workforce policies and funding, but in terms of how we are going to address the larger healthcare system issues that will, in fact, determine how successful we can be with many of the workforce-related issues that you've talked about today. And I'd also like to put Delaware in the context of sort of national statistics and also bring it back home in terms of what I see as some of the particular strengths and opportunities that I think you have to move forward in a broader way. But first, I hope many of you are already familiar with the Milbank Memorial Fund. We're very old, but in the last 50 years or so, we have primarily dedicated ourselves to building evidence and sharing experience among state health policy leaders to help them improve population health. We do that through topic-specific convenings. We have leadership development programs, which I'm sure somebody from Delaware has participated in, as well as the publication of many different types of resources, including the Milbank Quarterly, which again, I hope some of you are familiar with. Milbank.org will get you to all of our resources. So first I wanted to start by saying that while everything that was discussed today and will be ongoing after this meeting are critically important in terms of strengthening the healthcare workforce in Delaware, but we do have to recognize that the success of the healthcare workforce in Delaware is connected to at least two other key factors: the success of the broader healthcare system and our success in terms of population health. And of course, there are many different variables that surround those things. But as was discussed at the very beginning of this meeting, and I felt right at home from the very beginning with the video that Tim shared, strong primary care is the critical foundational component that supports all three of these dimensions. So what are the factors that are affecting the ecosystem? On the one hand, we know we have significant challenges. I thought of this as a triple threat. But we also have some significant opportunities. And do any of you know what triple espresso talks about? Yes? Okay, you can Google it. But basically, it was the 3 forwards for the U.S. women's soccer team. And they were really working as a team, the factors that contributed to the success that got us the gold medal in that particular sport. So to me, the triple espresso is these are the ingredients for putting things together to help to solve these very intractable issues. But first, I am going to pummel you a little bit with why this is so critically important to look at the larger healthcare system in terms of the workforce concerns that you have. So where does Delaware stand relative to other states? The good news is that you're not in that right-hand side of this slide. But the bad news is that you're not really at the front end of the left-hand side of this slide either. So you could draw some comfort from being right in the middle, but clearly it provides you an opportunity to explore opportunities for improvement. This is from the Commonwealth Fund State Health System Performance Scorecard, which they publish on a roughly annual basis. In addition to that, last year they published a health equity scorecard. And so I pulled the slides just to represent 3 population groups. For the white population, Delaware is looking pretty good, and the performance for white population is similar to the performance for the best performance of any population. So that's a good thing. Similarly, for the black population, actually, the performance is higher than a lot of other states. But as you'll see, there is a bigger gap between that top dot and the bottom dot. The top dot is the best performance. The bottom dot is where Delaware currently is. And so you see, again, opportunities for improvement. But I found particularly striking here from a population health perspective that the Latin Hispanic population clearly significant room for improvement in terms of health equity and health status measures. Affordability. This has been a big conversation in Delaware, including, I know, this past session. But this graphic just shows you the growing gap between increasing healthcare costs, and workers' salaries. And the trends here continue to diverge in this pattern, so it's not getting better. CMS just recently announced that their projection was that the healthcare spending will continue to increase at a rate which is greater than the overall economy. And so we have been working with some states, including Delaware, that have committed to trying to measure their own rates of healthcare spending growth. And this is a year-old data, so I apologize, I didn't have a chance to put in the more recent data that Delaware has published. But what you can see is, first of all, a couple of states, Connecticut and Delaware, really stood out. This is almost 20% per capita healthcare growth in 1 year on the commercial side. Not sustainable. Our best state, Rhode Island, managed to get in at about 10%. Also not sustainable, but half of the rate of growth in Delaware and Connecticut. We also know from surveys that more and more Americans are saying that they have difficulty affording healthcare costs, or that they are delaying or deferring care as a result of cost issues. And so you see here are on the darker blue side, people who say, not too much of an issue for me. On the lighter blue side, very or somewhat difficult. And part of what I would like you to notice here is that, well, we would expect that the uninsured population would find cost a big issue, right, if you don't have coverage. But look at the insured population, almost half said that they have difficulty accessing care because of cost. Insurance alone does not guarantee that you can afford your care. We see some differences in terms of populations, and also, obviously, some differences in terms of income groups. But I'm going to come back to this issue of people with insurance, because it is also clear from this particular survey question, which was, how do you rate your health insurance in terms of your ability to, what are your out-of-pocket costs, the amount that you have to pay for your health insurance, out-of-pocket costs for a prescription. And look at that dark color. That is people with employer-based coverage. Half of them said that they were paying too much out-of-pocket. Half of them, almost half of them, said that they were paying too much in terms of their premiums. And we know that although I think this trend is starting to change, during a period of time when healthcare costs were growing so much, the strategy that most employers were using was to simply pass more costs on to consumers. And you see that very clearly in terms of the impact that that has had on people with insurance. I was glad to see a lot of attention to issues around dental care and oral health today. And you can see that dental services top the list of services that people are most likely to delay because of cost. But there are others as well, including 25%, almost, a visit to a doctor's office, or utilizing hospital services or mental health care. So I don't go through these very quickly, but I'm sure you'll get a copy of these slides and you can examine the data, as well as, in all cases, I've given you the data sources so you can look more deeply at some of this information. Today, as a result of some of this accumulation of the passing on of cost to consumers, we now are hearing a lot more about medical debt. And again, what you see here are variations among states in terms of the percent of people who are reporting medical debt. This is a national survey. But I was particularly interested to see this new study that appeared in a JAMA article in the last month or two, which is that healthcare workers are actually ones who will be very likely to be incurring medical debt. And that there are significant variables in terms of gender, race, income, place of employment, et cetera. So this is all very much coming home, not only for the people you serve, but for you and for your family. And again, these trends are growing except to the extent that a lot of states are now taking some action to try to reduce the amount of medical debt. We talked a little bit today about the impact of healthcare consolidation. The last question that we had, or comment, was about the increasing degree to which hospitals and physician practices are now part of larger health systems. This has a double-edged sword. It has been seen as a way for some of those hospitals and practices to gain some financial stability, but it also has resulted in increased cost. And so we see that there's, as in many cases, a little bit of a squeezing balloon factor there. And finally, since I know that Delaware is very proud of its record in terms of increasing insurance coverage, we have a little bit of a mixed bag in terms of the overall trends. Health and Human Services at the national level just reported that we have the lowest uninsured rate in 2023 after, of course, significant increase in enrollment in ACA plans. But there are some nuances to these findings that indicate that there could be some difficulties ahead of us. We can't assume that this success in enrolling more people in some form of coverage will just remain the same. The marketplace enrollment has been great, but it's really thanks to the subsidies that are available through the federal government. Once those subsidies go away, those plans will become increasingly unaffordable for those individuals unless some form of federal subsidies continue. And I think you all know that this is a topic for discussion over the next few weeks. Medicaid unwinding in some states has resulted in an increase in uninsured. And of course, we know there are a rising number of immigrants who are not necessarily able to access either public benefits or employer benefits. So overall, what we're looking at is a long-term increase in the uninsured, which again will pull us back from some of the progress even that we've been able to make in that space. So these are just all factors that are going to affect the degree to which the health system itself will be able to successfully participate in all of the great workforce initiatives that we have been talking about today, and also the degree to which the public will be able to access those services. I'd like to talk a little bit further about primary care. This is a major focus for the Milbank Memorial Fund, as I know it is for the Academy and for Delaware Health Force. But primary care, the foundation for better health care and population health, is in trouble. I'm just going to briefly review what we're seeing at the national level. National Academies of Medicine, Science, and Engineering had a land-breaking committee report back in 2021 that brought focus to the importance of primary care. But what they did was they also really expanded the envelope of what we think about as primary care, and I think it's very consistent with both the spirit and the activities which all of you have been involved in. It described primary care as the provision of integrated, accessible health care from clinicians who are accountable for addressing a majority of personal health care needs, developing sustained partnership with patients, and practicing in the context of family and community. In this instance, primary care is a broad concept, including a range of providers and services. But they go even further to say that high-quality primary care includes team-based care, continuous, person-centered, relationship-based. These are what they describe as the characteristics of high-quality primary care. And they contended, this is not me, they contended that primary care is the only part of the health system that results in improved population health and health equity. I think that's based on the evidence that they were looking at for purposes of this committee. So coming out of this, we have a lot of policy action and beginnings of accountability around measurement and public information, establishing baselines and assessing progress towards trying to improve, to strengthen our primary care system. One is a national health of primary care scorecard, which was recommended by the NASM report It is sponsored by the Milbank Memorial Fund. We have an analytics partner with the Robert Graham Center, which is part of AAFP, and we have funding from the National Physicians Foundation to support this. In addition, Delaware, along with many other states, have set primary care investment targets, and there are examples now of state-level primary care scorecards that help to amplify and deepen our understanding of what needs to happen to improve primary care at the state level. So I'll just give you a few selected examples from those three areas. This is just some press coverage that resulted from the NASM report. Our first national scorecard, we wanted to try to communicate more strongly what's going on here and why it's so important. A sector in peril. We had 4 key takeaways, and this was following the framework that the NASM report gave us. Systematic underinvestment in primary care, a shrinking workforce, too few physicians being trained in community settings. We talked about that periodically today. And almost no federal funding for primary care research. So obviously we're not building a bench to improve our research capabilities there. So that was good, and we got some attention from that first scorecard. But then we felt, you know what, the situation is getting worse. We need to bring even more attention to it. So this was our dramatic headline for last year's report. No one can see you now. This is what we hear, you know, day by day from consumers. And we reiterated, but also expanded on some of the themes from that first scorecard. Primary care workforce is not growing fast enough. The number of trainees who are entering and staying in the professional pathway is too low. And again, too few have community-based training. Technology, which we thought was going to help, has actually become more of an added burden to primary care. And again, we called out the lack of funding for research. I'd just like to show you a couple of examples from Massachusetts and Virginia of what they have done in terms of building on this concept of a scorecard and expanding on it to address what they felt were the key factors in their health system that they wanted to amplify and to continue to report on. And so in Massachusetts, they've had now 2 or 3 years of reporting. It's a collaboration between the Massachusetts Health Quality Partners, a nonprofit entity representing providers and health plans, and the State Center for Health Information Analysis. And they are looking at 4 broad domains. What are we spending on primary care? What is the capacity of the system? What is the performance of the primary care system? And how is primary care addressing health equity? And this is just one sample of what they are able to do using the data that they have collected and that they are getting from the state. And it clearly shows that if you just looked at the state as a whole, you would get one answer. It would be an average. But there are clear regional disparities in terms of key access measures. I'm sure you would see the same if we had this kind of data capacity in Delaware. But obviously, this is an important tool in terms of talking to policymakers and to health systems about why the investment in primary care is so important. In addition, Virginia has had a primary care scorecard now for a couple of years. They have their own set of domains looking at primary care spending, utilization, workforce characteristics, outcomes, and patient experience. And you'll see what they have done then is summarize that in a very nice, graphically friendly one-pager, which they can give to legislators and others to help them to really simply understand what are the challenges that we are facing. And one example that they were able to show very clearly was the impact of COVID in terms of the availability of primary care. So again, we know that COVID had this kind of impact, but here we have a graphic that shows you exactly what that impact was and also what the impact was regionally in different counties. Again, I think that legislators and others in the community can really take stronger action if they know what's actually going on in their own community relative to others. So, all right, I've painted now this sort of bleak picture of all of the problems, and as one of the other speakers said earlier today, I am going to talk about some opportunities because I think there are many, and we have many positive ingredients in Delaware to move forward with, both at the federal level and state, to create a more sustainable healthcare system. And you're moving in the right direction, but there clearly are opportunities to do more. Delaware is one of several states that adopted a cost growth target program. I gave Delaware credit for this one, which I realized when I looked at the map this morning, you don't get credit for this one, but I'm going to work with some of the legislators who were here earlier, and maybe we can get some bills moving this coming year. But this is basically to try to deal with what are some of the anti-competitive practices that are going on in healthcare contracting. And then finally, a growing number of states, of which Delaware is participating, that have primary care investment legislation in place. There is great alignment already between what's going on at the federal level and what's going on at the state level. At the federal level, the Department of Health and Human Services convened its first ever primary care task force. Hard to imagine, but that's true. They are using 1115 waivers. These are Medicaid waivers that allow states some flexibility in how they design their Medicaid programs to encourage states to make investments in these areas. And there are new demonstration program authorities to push the envelope on new kinds of payment models. We think particularly important, and any of you who are involved in the primary care world who are here today, the proposed changes to the Medicare fee schedule for the first time would provide an enhanced payment under fee-for-service for care coordination, for preceptor things, many of the things that we talked about today. These are proposed rules. The more comments that they get in favor of these rules, the more likely it is that these will become features of the future Medicare fee schedule. And then finally, the Agency for Healthcare Research and Quality is working on both primary care spending measures as well as a new program for practice transformation. Here in Delaware, we've got a cost growth benchmark program that's trying to address affordability, the work of the Insurance Department's Office of Value-Based Care, obviously the Primary Care Reform Collaborative, which is an active member of this group, and the Medicaid ACO, which is a first step in the direction of utilizing that Medicaid 1115 authority to enhance the Medicaid program here. Medicaid has some additional tools that it can provide to address workforce needs. I just gave two examples here, one on the left relating to behavioral health, and one on the right relating to home and community-based services, the topic of that last panel. So again, you will get these slides so you can look at some of the specific examples of strategies that are being approved by the federal government for Medicaid. And they're really pushing the envelope with some of these new Medicaid 1115 waivers. I have lost track of how many billions of dollars New York State has now gotten through these waivers. So I think Delaware should look into how they can further enhance their funding from the federal government as well. But look at this combination of factors. First, it is focused on health equity. So this is the Medicaid program focusing specifically on health equity. It is doing so with a combination of a hospital global budget initiative, don't throw darts, health-related social needs funding, and workforce initiatives. And this concept of a health equity regional organization. And I called this out because, okay, so that's at the state level. This is what the state health department is doing in New York. But these health equity regional organizations are public-private partnerships, very similar to the kind of structure that you have in place through HealthForce, as well as some of the other initiatives that were described today. And so in this case, the Iroquois Healthcare Association, which represents a broad array of healthcare providers in upstate New York, was selected to serve as one of the 3 high-performing workforce investment organizations under the New York Health Equity Reform 1115 waiver. So I just really wanted to call this out as a potential opportunity for the state of Delaware and the stakeholders that are here to explore further, either with the folks in New York or with the folks at the federal level. We also had brief remarks earlier today from the Workforce Investment Board. Here in Delaware, Washington State has a Workforce Investment Board as well. And one of the things that they created was something they call the Health Workforce Sentinel Network. And this was actually begun before COVID, but obviously came into great utility during COVID. And just basically the idea here is to have a data hub that has real-time information about the employment opportunities and the employment needs across the entire spectrum of the healthcare system in the state of Washington, so that you can pinpoint education, training, job placement, and other services in a more strategic way. I think it's a very interesting example. It's very data-driven, so it takes some time to put it together, but just another thing to consider. And it actively includes employers as part of the equation, which I think sometimes is not the case for some of the public policy initiatives. So in closing, today's conference obviously reiterates the need for strategies to train and support a bigger, more diverse, flexible workforce to meet Delaware's population needs. But my basic point for you today is focusing on workforce alone is not sufficient. We have to go back to that interrelationship of the ecosystem, how healthcare workforce relates to the characteristics of the health system, how the characteristics of the health system have to relate back to our goals for improving population health. Let's put it a different way. A health system that is not performing well is not going to meet the needs of the healthcare workforce, and a health system that is not performing well is not going to improve population health, which really should be our higher level goal. So we come back to that foundation, stronger primary care and behavioral health, and we just have to really keep our eye on the ball in terms of focusing on that. So creating a better ecosystem requires strong leadership. I believe you have that here, but you could always cultivate more. Common goals with accountability. This is looking across the silos. And then partnership, how those silos could connect together in a more meaningful way. Building and using evidence. Data, data, data. I hope, Tim, that you and others here can continue to focus on building your real-time and also research data capabilities to continue to draw attention of policymakers to these needs, to focus on building systems that will make healthcare more affordable, address population needs, and make healthcare practice safer and more rewarding. And finally, I think key thing here, especially in a small state, because I worked in New York, but then I also worked in Vermont, is to be able to scale those system investments. And this may be the hardest part, because it really requires strong alignment of plans and providers, of the employers and the state, to standardize and enhance primary care, behavioral health, and population health investments. If everybody is doing everything their own way, we will not be able to scale these investments effectively. And I think that's particularly true in a small state. So I truly appreciate your invitation today, the commitment that I heard from everybody in the room. As I said, I think that there are many positive things to build on, but there is more to do. And thank you.